Okay, let's go ahead and move on to the second major part of the schizophrenia chapter, and that is to look at cause and treatment of this disorder. As I mentioned to you, it's one of the most complex disorders just in terms of symptoms, so of course the same is true for cause. There are biological, psychosocial, sociocultural, family, interpersonal causes all interwoven. So we're not going to be able to talk about all of them, but I do certainly want to spend some time talking about the major ones. Before I get into the causes, I've mentioned that schizophrenia usually doesn't begin to show itself until the late teens or early 20s. But we do have some clues for many people looking back that there may have been the setup, the precursors for schizophrenia were there. So I want to mention just a couple of developmental precursors that researchers have found. Now, remember, these aren't things that predict schizophrenia. What researchers have done is to take adults with schizophrenia and then look back at their childhood to see if maybe anything was off. Maybe there were some early clues. And this is one thing that they have found. They have found that, and the first studies were done in the 1990s, looking at home movies or home videos of kids were one of the best ways to look at this kind of thing. And they found that for adults with schizophrenia, they were more likely as kids to have unusual hand movements like hand flapping, repetitive stereotypical hand movements. And they also had expressions that were more negative and less positive. So kids with schizophrenia as adults, I should say, people with schizophrenia as adults, as kids, tended to have more negative expression and fewer positive expressions. And then this was verified again in a 2001 study that found that kids with schizophrenia had unusual motor behaviors when they were kids. Again, overly repetitive, kind of atypical behaviors. We would never diagnose a kid with schizophrenia unless in the very rare instance they actually had psychotic features, which is very unusual for kids. But these kinds of behaviors are also pretty typical for kids who are on the autism spectrum, as we just talked about. So right now, the diagnostic challenge would be if a child presented with these, is this autism spectrum or is this something else? This also does not mean that any kid that presents with these things has schizophrenia or is going to have schizophrenia, but it is a sign that perhaps something is going on that needs to be examined or take a look at. Okay, so when we talk about the causal factors, of course, we first have to start with biological and genetic factors. Unarguably, genes make some individuals vulnerable to schizophrenia, and these studies actually started quite a while ago, back in the 1930s, and researchers found a link between a parent's schizophrenia and the child's tendency to also develop schizophrenia. They do not inherit a predisposition for a certain kind of schizophrenia. They just inherit a general predisposition. So, of course, first of all, there have to be twin studies, and the twin studies are pretty conclusive. In general, the concordance rate between identical twins, the monozygotic twins, is 46%. So that means of 100 people who have schizophrenia who have an identical twin, roughly half the other twin will also have schizophrenia, because obviously these twins share identical genetic material. For dizygotic twins, fraternal twins who share less genetic material, there's about a 14% concordance rate, which is about the same as it is for just a regular sibling. It's not really very different. So obviously, if schizophrenia was 100% genetic, we would see this number here for the monozygotic twins be 100%, but it's not. So what that tells us is that something else is going on with the transmission of schizophrenia besides genetics. This next chart I think is really interesting. Of course, you don't have to memorize this or anything like that, but what it shows us is that the greater the similarity of genetics, the higher the risk for schizophrenia. So identical twin, we just talked about, there's about a 46% likelihood. In the very rare circumstance where both parents have schizophrenia, about a 46% likelihood that the child will also have schizophrenia. And then as you decrease genetics, these numbers go down. So a fraternal twin or just a sibling, pretty close, 10 to 14%. If one parent has schizophrenia, the other does not, about a 13% likelihood that a child will develop schizophrenia, and then, of course, less related people, it's pretty much down to nothing, down to zero. You know, in order to get research on these numbers, there really have to be large-scale longitudinal studies looking at groups of people, families, people who have genetic similarities. And I'm going to tell you about one here in a little bit. But one of the very first ones that was done, and your book talks about this, was a study done on 4 girls, quadruplets, that they gave the pseudonym the Janane. And Janane is actually translated, I'm not sure what language it is, but it's short, it's translated into dreadful Jean. It's a story about, or it's a research about 4 girls, identical girls, who were born in 1930, right around 1930, and they have been followed for years. These girls had a really hard upbringing. You know, quadruplets at the time were just such an unusual thing. Their parents either had suffered from some mental illness, or were just bad people because they socially isolated the girls. They charged admission for people to come and look at them because it was just such an odd thing. But then the hardest thing that they did was they treated them as 2 separate sets of twins. They kind of treated them as a superior set and an inferior set. So 2 of the girls who seemed to be higher functioning were given an education. They were treated much better. The younger 2 were given extreme restrictions and surveillance. There's evidence that the father may have abused 2 of the girls, and there's also evidence that the father had mental illness in his family. According to records, it appears that his mother, so the girl's paternal grandmother, may have had schizophrenia that was diagnosed. Other just really weird stuff. The inferior 2 girls were given clitoral circumcisions because the parents or the dad didn't want them reproducing. But anyway, the bottom line is that all 4 of them, so they were treated as 2 sets of twins, but all 4 of them developed schizophrenia by the age of 24, between the ages of 20 and 24. But what was really interesting about it is that the superior set just did much better than the inferior set. One of the girls of the superior set, and I don't know their names to say, finished college, got some employment, married, and had a couple of kids. And then the other one in the superior set was able to hold down employment, although she did not marry and have kids. The girls in the inferior set, and I don't know who is who in this picture, did not do nearly as well. One of them had to be taken care of and lived in an institution for a good part of her life, and the other one just also needed a lot of care. So we've got 4, here's kind of the environment versus genetics. We've got 4 individuals with supposedly identical genetic material, so they all developed schizophrenia, but 2 of them did much better than the other 2. And I've tried to keep up with them to some extent. This was a longitudinal study that's still ongoing. The last I read was, as of 2013, the 2 sicker women had passed away, which makes sense because the mortality rates for schizophrenia are much higher than the general public. And if these 2 women were more ill, that would make sense. And then the other 2, I'm not sure about. I mean, they would all be 90-ish now. So I haven't been able to find any other information about them. But they were able to support themselves and each other really through the money from the media interest onto them. So anyway, the bottom line of this particular study is to look at the intersection of the environment and biology and genetics. And so we know genetics isn't the whole picture, and even if you have the genetic vulnerability, environment can make a big difference. So that leads us to looking at the second way that scientists study the role of genetics, and that is through adoption studies. Adoption studies are really used to tease out the separate role of the environment and genetics. There are generally 2 ways of doing adoption studies. The first one is through what's called the adoptees study method. What this involves is finding individuals who have schizophrenia, who had a child who was adopted by another family. And then we go and look at that child. So let me say that again. We find adults who have schizophrenia who had a child. It could be the mom, it could be the dad. In a very rare circumstance, it might be both. They have a child, had a child, but that child was adopted by another family. And then we go and look at that child to see if the child who has been raised in a healthy family without illness still developed schizophrenia. That's that method. Similar, but a little bit different, we have the adoptees' relatives methods. In this one, we find people who are adopted who have schizophrenia. So we find adults who have schizophrenia, but they happen to be adopted. And then we look at their biological family and we look at their adopted family. So what we know through both of these studies, the result is pretty much the same. Even when raised in a home other than that of parents who have schizophrenia. So these are people who are raised in a home where there is not schizophrenia in the adoptive parents. Children of biological parents with schizophrenia still have a higher chance of the disorder. In other words, the genetics trumped over the healthy environment. So something other than living in the home of someone with schizophrenia must cause it. Because the thinking was, okay, if your mother, let's say, has schizophrenia, and then the mother has children, do the kids develop schizophrenia because of the genetics or because they're exposed and are raised with a person who has schizophrenia? And the results of these studies show that it seems to be the genetics that's the higher component. Okay, now what about for people who develop schizophrenia or don't develop schizophrenia and have parents with the genetic vulnerability? Now, we already talked about this model with bipolar disorder, so I'm hoping you'll understand it. What about children who develop schizophrenia even though their parents don't have it? So let's take that same model. We've got identical twins, one who has schizophrenia, one who is healthy. Let's say each of them have a child. Each child has a 17% likelihood of developing schizophrenia themselves, even the child of the healthy parent. What that shows is that you can have the genetic predisposition for schizophrenia, not develop it yourself, and still pass it down to your child. Okay, what about fraternal twins? So we've got one twin who has schizophrenia, the other who is healthy. This is different. These people do not have the exact same genetic material. This child still has a 17% likelihood because the parent has it, but this child, this particular twin may not have inherited that genetic vulnerability, and so their child has a much more distant chance of developing schizophrenia. So again, the stronger the genetic links, the higher the likelihood of developing the schizophrenia. Now, a lot of you may have seen, and if you haven't, you have to do this immediately. This is one of my strongest movie recommendations for you this semester. You must all see A Beautiful Mind if you're interested in abnormal psychology and psychology. Russell Crowe, this probably came out close to 20 years ago, I would say, but it is the true story of John Nash. Here's a picture of him here, who was at Princeton, I think, educated, or Harvard educated, Ivy League school, and he obtained mathematician, and he obtained a professor position at an Ivy League school and developed schizophrenia when he was actually a little bit older. And so the movie is about his life, and he goes on to win the Nobel Prize. And I say you need to see this because Russell Crowe does an incredible job of portraying him. One of the scenes that I will sometimes show my class, I didn't link it for you here, is his hallucination scene when he goes into the shed and he basically developed delusions and hallucinations. This was during the Cold War that this occurred, 1950s or so, and he was contacted by the American government, some secret agency in the American government, and was asked to intercept messages from between Russian spies and Russia. And so he dedicated a lot of time to analyzing newspapers and all the while suffering and dealing with schizophrenia. So this video clip I want to show you. Now, he managed to basically help himself, and through the use of medication, I wouldn't say that he recovered fully, but he was highly functional in his later years. And so if you watch this video clip here, it's an interview with the real John Nash. They also bring his son in and they talk a little bit about his winning of the Nobel Prize. This is one of the absolute must-watches from this chapter, and I will link that at the bottom in the description of this. John Nash, unfortunately, he and his wife died 4 years ago in a car crash. I think it was in New Jersey. So what an unfortunate ending. And what a sad ending. And he was working up until the end. So be sure and take a look at that. Okay, hang with me. Let's get a little bit more deeply into the neurobiology here. I know I've mentioned before that genetics affects brain functioning, both brain structuring and also the neurotransmitter functioning in the brain. So a study that was just done a few years ago and published in just an incredibly esteemed journal, it's a biological journal, Nature, took a look at 65,000 subjects on a variety of things, but schizophrenia was one of the big things they look at. Now that's obviously a really respectable sample size. So what they found is that people with schizophrenia in general, they found a lot of variance in the C4 gene. They found variance in the C4 gene in patients with schizophrenia. Now I've got this arrow in the wrong place here, but the C4 gene is linked to synaptic pruning. Now, if you remember from a developmental course, I know I teach this in my adolescence course, but during the teenage years, the connections between our neurons are pared down, they are pruned. So throughout childhood, synapses are built between neurons, connections are built between neurons, but really it's more than what you need. So during adolescence, the process of puberty helps to winnow those down, narrow those down to only the connections that you need. So that's a normal developmental process that needs to happen. But in general, patients with schizophrenia have fewer neuronal connections. So what we're saying here is that C4 variant seems to speed up or make excess that synaptic pruning so that in adolescence, the pruning process goes too far. That may also be why the first symptoms of schizophrenia begin to show up in adolescence. So there are fewer synapses in people with schizophrenia, and so that leads to a thinner cerebral cortex, which of course is in charge of our higher reasoning and functioning. So here's a picture kind of showing how this process happens. So at birth, you can see these are neurons. There aren't a lot of connections between the neurons. Early childhood here, there are lots of connections. So that's as brain growth happens. And then between ages 14 and 16, there are fewer connections because basically it's a way of only connecting neurons that we need the most or that we use. If you are a little confused, here is a quick video, and I will link this in the description part that I'd like you to take a look at that explains that synaptic pruning process a little bit more. So here's another way to summarize it. Excessive synaptic pruning during adolescence, because of that genetic C4 activity, could be a clue to the development of schizophrenia. So we know that for people with schizophrenia, that process may be excess. So that's really big news because potential treatments are being developed to try and turn down that synaptic pruning for those at risk or those who show early symptoms. So for a typically developing adolescent, we wouldn't need to do anything, of course. But for adolescents where there is genetic risk of schizophrenia in the family, or for those who have been showing some of those developmental precursors that I talked about, these treatments might be helpful and might prevent the development of full-blown schizophrenia. So something to keep in mind. That's some of the newest research. Okay, now, before I move on to talk about neurotransmitters a little bit more, I want you to remember that schizophrenia is not caused by one gene. So I mentioned that C4. That seems to play a role, but we know that there is not one gene that's been isolated that determines whether a person's going to develop schizophrenia. And that's pretty much true for most psychological disorders and physical diseases. They are complex, they are polygenic. Multiple genes combine in different ways to determine a disorder. And this also explains why the risk of having schizophrenia increases with the number of affected people in the family. So essentially, the higher genetic transmission, the more at risk a person is to develop symptoms. Now, the genetics, as I mentioned, it influences those synapses, it influences the neurotransmitters. So let's talk a little bit about the neurobiological influences. The most enduring theory of the cause of schizophrenia involves the neurotransmitter dopamine. So remember, with synaptic transmission, we've talked about this, but let's use this sketch. So we have neurotransmitters. We could say these are dopamine, we don't know. That when the neural impulse comes in, the neurotransmitters move here to the end of the terminal button and they release neurotransmitters into the synaptic gap, and these neurotransmitters bind onto the dendrites of the postsynaptic neuron, and then the whole process continues again. So with dopamine, we know something is going on with the dopamine transmission of people with schizophrenia. The way that this was discovered was by studying drugs that affect dopamine functioning. So, for example, agonistic dopamine agents increase neurotransmitter activity. What that means is when we give patients with schizophrenia, or really anybody, dopamine agonists, this increases the amount of dopamine that is released. So that's one thing that we can look at. Another thing that we can look at are dopamine antagonists, which decrease or block the neurotransmitter activity. So if we go back here, those antagonists will slow down that dopamine activity. So agonists increase the activity, antagonists tend to decrease the activity. Now, what does that tell us about dopamine? What that tells us is that antipsychotic medications are dopamine antagonists. So the medications we use to reduce schizophrenia symptoms slow down the transmission of dopamine. So what that tells us is that there is probably excessive amounts of dopamine getting through for patients with schizophrenia. So antipsychotics are dopamine antagonists. These dopamine antagonists also cause Parkinsonian's disease-like effects. So Parkinson's disease, which is not schizophrenia, it's a physical disease, is caused by depleted levels of dopamine. So when we give patients with schizophrenia dopamine antagonists, it reduces the level of dopamine getting through. And some of the side effects are some of the effects of Parkinson's, the tremors, the difficulty with motor activity. So I'm not saying that when patients with schizophrenia get antipsychotics, they develop Parkinson's disease. They do not, but they develop side effects that are very similar to Parkinson's disease. Now, each neuron has different dopamine receptor sites. So far I've been talking about how, okay, let's say all these are dopamine receptor sites and the dopamine binds onto these receptors. Well, they actually have different names. For example, for dopamine, we have D1, D2, D3, and I'm just saying that that's what these are, D1, D2, D3. So dopamine binds onto different receptor sites, and what makes this so complex is that these dopamine receptor sites have different functions. So the traditional antipsychotic medications that have been around for a long time usually block the D2 receptors. So they've been very specifically modified so that they block the D2 receptors. The problem is that doesn't necessarily stop all symptoms that go along with schizophrenia, all of those behaviors. So when we talk about medication here shortly, we're going to see that some of the newer medications help block other of the dopamine receptors, and they've also targeted serotonin additionally. So the picture's a little bit more complicated than knowing exactly which dopamine receptor to focus on. This next slide, this is also a quick video I'd like you to take a look at. It does a nice job of describing how antipsychotic drugs work. So you can either go to the unrecorded lectures part of Blackboard, or I will link these down in the description section. Okay. So a third way, so we've got genetics, neurobiology. A third way that we know schizophrenia seems to be caused is by looking at brain volume and brain structure. And this one hasn't been too difficult for scientists to study because of technology. We can run people with schizophrenia through MRI machines, fMRI, and PET scans. The fMRI and the PET scans don't just show a structural picture, but they show the activity of the brain. And those are important in addition to MRI scans. So here, for example, when we look at scans of schizophrenia patients and those who don't have schizophrenia, what we see are enlarged ventricles. So here is a patient who is free of schizophrenia. Here are the ventricles. Here is a patient. Now these are monozygotic twins. So this is the twin with schizophrenia or without. This is the twin with schizophrenia. And you can see that those ventricles are significantly enlarged. The ventricles are actually spaces in the brain that are filled with cerebral spinal fluid. And cerebral spinal fluid is just the fluid circulating in the brain cavities filled with cerebral spinal fluid. Now, we also see brain ventricle size issues in patients with Alzheimer's and alcohol dependence. Now, obviously, that's not schizophrenia, but we know that that ventricle size plays a role. So the ventricle size may be one issue, and they don't exactly know what causes that to change between one twin and another. Other brain structural abnormalities we see are differences in size and functioning of the hippocampus, which of course is largely in charge of memory, and then the thalamus, which has to do with sensation and sensory relay. And of course, that would be responsible largely for hallucinations in patients who have schizophrenia. Okay, one last biological cause here to mention, and that is the role of maternal influenza prenatally. So there is some evidence, and it's not huge, but it's significant, that mothers who have the flu prenatally during the 4th to 7th month pregnancy are slightly more likely to have babies at risk for schizophrenia as adults. This isn't reason for anybody to panic, but this is something that researchers are going to take a little bit more of a closer look at. Generally, when women have the flu, their OB-GYNs, if they are under care, will really stress the importance of getting the flu shot, because the flu shot the flu can be dangerous for people, especially someone who we consider a little bit more vulnerable, like a pregnant woman. But this just adds a little bit more information that it's especially important. So anything we can do to prevent would be helpful. Okay, so I guess I lied. This is the last biological piece that we'll mention here, and that is the role of cannabis. This is actually some of the newest research that's been coming out, and it's really interesting and it's really significant. So a study that came out a couple years ago in The Lancet, which again is a leading medical journal, has found a link between regular smoking of marijuana when a person is younger and their susceptibility to schizophrenia. Daily marijuana smoking raises the risk of psychotic behavior by 3 times when people, and this is when people are younger, before they develop schizophrenia. So this is usually during the teen years is what we're talking about. People who smoke the high potency marijuana daily are 5 times more likely to develop schizophrenia. That's a really significant difference. I'm going to show you a graph here in a minute, but having a family history of schizophrenia may even increase a person's susceptibility to the effects of marijuana. So it's especially dangerous for people where there is a family history. Now, this graph shows you just some examples. Cannabis consumption at age 18 and later risk of schizophrenia. So what is a person's consumption at age 18 and later risk? So the number of reported occasions. So by the age of 18, if a person has reported at least 50 occasions of smoking marijuana, then there's an average of about 28 cases per 1,000 of schizophrenia. That doesn't sound like a lot, but when you compare it to 0 or 1, I'm not sure why 1 is a little bit lower. That may just be an artifact, but just the average number in the community is here, and then it steadily rises the more incidents. So they have not examined people who smoke marijuana for medical reasons. This is meant to be more for recreational use, but just something to keep in mind that there are links to this, and they are going to continue to study this. Now, so far, everything that we've talked about with biology and genetics, as I've mentioned, makes a person susceptible or vulnerable to schizophrenia. So now it's time to take a look at how those biological vulnerabilities interact with the environment to actually trigger the disease. We call this the diathesis stress model. This is the best way to explain and understand the interactions of genetics or biology and the environment in causing schizophrenia. The name diathesis stress is a little bit wordy, but really what this means is diathesis refers to the biological piece, the genetics biology, and the environment, of course, refers to the stress piece. So a question is, okay, if a person has a genetic vulnerability to schizophrenia, what kind of stress would be enough to trigger an episode or trigger the disease? That's really a tough question. What stressors can precipitate schizophrenia? And we have some answers. We have some answers about some specific stressors. Now, this next slide I'm going to show you is a graph, and it shows that a threshold exists. So the idea is if you have a lot of genetic vulnerability, so that if there are a couple of people in your family with schizophrenia, it will take fewer environmental stressors to trigger schizophrenia than someone who does not have that genetic vulnerability. So if there is no schizophrenia in your family, it will take a great deal more serious stressors to trigger an episode. So here's what this and I just hand drew this out, looks like. So what this tells us here, down here is the is this the vulnerability? Yes, here are the events. So minimum events and maximum events listed here. And then down here is your biological vulnerability. So if you are a person who does not have much genetic vulnerability, there's no schizophrenia in your family, it's going to take a lot, the maximum amounts of stress to kind of throw you over that ill mark and into illness. Versus down here, if you're a person with a lot of genetic vulnerability, if several people or a couple people in your family have it, it is not going to take nearly as much stress to throw you over into that ill zone. And that's what this means. So it really is a linear type of relationship. One could say it's an inverse correlation. So the lower your genetic vulnerability, the more stress is necessary to trigger schizophrenia. There is, this is interesting, there is a book, and I wish we had known this really prior to our assignment. There's a book that just came out this year called Hidden Valley Road. It's making the news circulation right now, the author's on the book tour, that it's just this fascinating account of 12 kids who were born to a family, to parents in the 1950s and the 1960s. 6 of the boys developed schizophrenia. Incredible, just an incredible number. And so the book tells about kind of their journey, and it's also a book that talks about how the thinking of schizophrenia has changed in the medical system. Initially, the mother was blamed, as we're going to talk about here. They used to, in the old Freudian sense, blame the mother for everything. But as they studied their family and the parents offered the kids in the family up for study, they began looking at things like gene mutation, the role of medication. So they moved away from that blaming of the mother, and this is the perfect opportunity to look at how genetics have affected this family. So the book is, I mean, there is a trigger warning with this. There was some abuse in the family. One of the brothers, actually 2 of the brothers were pretty violent. One perpetrated some sexual abuse against one of the 2 youngest were girls. The older, I guess 10, were boys. So 6 of the boys developed schizophrenia. A couple of them have died already. And it's kind of like the Janane family. 1 or 2 of them has done okay. Several of them have not done well at all. But if you're just looking for something to do for your summer reading, it's a really, I have it on order, but I hear it's a really fascinating account. Combination of genetics and environment. Okay, so let's talk a little bit more about some of those environmental stressors. What could be enough really to trigger? One of the main ones that's been examined is the role of social class. We know that people with lower socioeconomic status tend to be disproportionately affected by schizophrenia. So people of lower socioeconomic status have higher rates of schizophrenia, and the question we need to ask is, why does that seem to be? There's 2 possible theories about why this is. First of all, lower socioeconomic status, so income problems, trigger schizophrenia. That's one possibility. So the idea is that the stress of low income is the stressor that triggers schizophrenia. And the other one is that schizophrenia leads to lower socioeconomic status. So let's take a look at each of these. Both of these possibilities, both of these theories have merit, by the way. So we have two theories to explain how these mechanisms work. First of all, the social selection theory, and this supposes that as schizophrenia develops, individuals just can't maintain the higher standard of living they have, and they kind of drift into poverty. So really they become just too impaired to work. So schizophrenia causes a person to lose their job and then their family. Oftentimes people will turn to substances as they're developing schizophrenia because it's a way of self-medicating when they don't know what's going on and they don't know what else to do. So that happens very commonly. And then the sociogenic hypothesis is the opposite. This talks about how the stress placed on an individual by poverty triggers and induces the development of schizophrenia. So poverty involves things like a lack of food, lack of housing, the stigma, that's the stress that's involved. So both of these theories seem to have some support. We can't say that one is better than the other. They both have been supported through research. Now, what about the role of family in developing schizophrenia? Family has been found through research to play a role, but it's probably not in the way you think about it. So I want to start with a little bit of history here. The old thinking is that, like with the Hidden Road book that I just told you about, that the mother, so this is old Freudian thinking, tended to cause schizophrenia in her child. Now, they actually came up with a name for this terrible Freudian name, the schizophrenogenic mother. So for a long time, the schizophrenogenic mother was thought to cause schizophrenia. And this is a woman who is rejecting and smothering at the same time. So for example, if let's say a son goes to give his mother a hug and she kind of stiffens up and pulls away a little bit, and then he releases her and she says, "What, don't you love me anymore?" So it's conflicting messages. Now, we have absolutely no research to verify that. The mother doesn't cause schizophrenia, but I like to talk about this because it shows just how far we've come in terms of our thinking, fortunately. Now, what we have is some evidence that patients with schizophrenia are more likely to have experienced some kind of trauma as a child. That could be abuse, it could be neglect, it could be sexual abuse, it really could be anything. And again, every kid that experiences trauma by far does not develop schizophrenia, but we know that of the adults who have developed schizophrenia, quite a few have experienced trauma, some kind of childhood trauma. So what is the current thinking on the role of family? It has less to do with the triggering of schizophrenia and more relapse and remission. So it doesn't really impact, except maybe that early trauma, whether a person develops schizophrenia, but their prognosis once they have it does seem to be impacted by family. So this current thinking is that family patterns of communication lead to relapse or remission of schizophrenia. It is not the initial cause of schizophrenia. So most of the time this comes into play after a person has been diagnosed with schizophrenia, they get into treatment, and depending on the person's age, oftentimes family treatment is mandated because the person lives with the family and the family needs to learn what to do. So these things are discovered once the family eventually gets into treatment. And those patterns of communication they have found are very specific, and they are something called expressed emotion, or EE for short. Expressed emotion. Okay. Now, the first thing that I want to tell you what expressed emotion is and then tell you what it's not, because people get this confused all the time, I find. Expressed emotion involves the comments from family members toward the patient. The types of comments, especially critical comments made from the family member toward the patient. So, for example, this involves hostility. If a person has a delusion and is expressing it, if a family member says, "How could you think that? That's so dumb." That's high expressed emotion. or emotional over-involvement. So if a family member is trying to make too many decisions for the patient with schizophrenia or is intrusive in their life, that would be considered high expressed emotion. So these are comments made from the family member when talking to the patient. Here's what it's not. Expressed emotion is not the emotion expressed by the patient. And students make this mistake all the time. Expressed emotion is not the emotion expressed by the patient. It's the emotion expressed from the family to the patient. Now, what we want here is low expressed emotion, low number of critical comments. So families who express low expressed emotion are calm, they are low-key, they don't blame their family member for their schizophrenia, they understand it's not their fault. They exhibit an understanding about the disease, and they know it's not a willful display of unacceptable behavior from their family member. So it's just accepting, it's non-blaming, it's much more calm. That's what we want. LEE is what we want. High EE are the critical, hostile, blaming kinds of comments, the disapproval. People believe that their family member is actually responsible for their behavior. They believe they can control their behavior. This is not what we want. We don't want families with high expressed emotion. Studies find a big difference. Of those people with schizophrenia who relapse, only 10% come from low expressed emotion homes, but almost 60% come from high expressed emotion homes. This is a huge difference. This is regardless of how severe the schizophrenia is. So this shows us that people with schizophrenia do much better when they live with low expressed emotion families. That's really, really important. Now, the good news about this is it's somewhat controllable. You can actually teach families how to respond in a low expressed emotion way, and that may protect against relapse. So there are some tips. I don't think I have it on the next, do I have it on the next slide? No. I had it on another slide. There are some tips and suggestions for family members on how to behave with a person who has schizophrenia. And they basically include that, give them space, be calm, don't blame them. So you can teach families this, and that's why family treatment is really important for a patient who has schizophrenia. Now, the only problem with this research, even though it's found to be really important and helpful, is that there's now some controversy over blaming families for the development of schizophrenia. So suddenly it seems like we're blaming families if their patients don't do well and providing guilt and hurt for those family members. That's not how we're framing this. It's meant to be framed to use this research as prevention. So if we can teach people how to behave in a low expressed emotion way, we can hopefully prevent a relapse and help families learn to interact with patients and then prevent that relapse. All right, lastly, let's move on to talking about treatments for schizophrenia. So we've covered quite a bit of information, and I'm sure you all should be proud of your knowledge here. You've learned quite a bit just in this chapter. So if we were together as a class, and believe me, I sure wish we were, I would be asking you, for those of you who are interested in going into mental health in some way, how many of you are interested in working with people who have schizophrenia? And I would look around the room, and there might be 1 or 2 hands, but there might be 0 hands too. That's a very, very common response. And I would ask, why not? What keeps people from wanting to work with people with this disease? And I would get responses like, it just doesn't seem like there's much gratification in this work. There really isn't a cure. What can I really make a difference with this serious of a disease? So all those are really normal kinds of responses, but we absolutely need people to go into the mental health field to work with patients with schizophrenia. So let me talk a little bit about the treatments, and a lot of it is biological for sure. That's the mainstay, but there are psychological treatments that are badly needed. So many therapies have been developed for schizophrenia. Drugs are the most common. Even with drugs, the relapse rate can be high depending on the family situation and the compliance to the medication, so other treatment must be needed. So the optimal treatment for people with schizophrenia is this triangle. They need medication most of the time, not every time, but most of the time, social skills training, and family intervention. So I'm going to talk about all three of these things. The ideal psychotherapy is not some of the traditional ones. Psychoanalysis or insight-based treatment is no longer used. Now, if you watch the video that I linked back in the last video on Ellen Sachs, she's very open about the fact that she undergoes psychoanalysis a couple times a week, and that's always been her therapy. That is highly unusual for schizophrenia. It's just unheard of. And it works in her case because she's so highly functioning. Her intelligence is very high. She can handle it. But most people with schizophrenia, that is way too much stimulation for them, and it just is not indicated. So insight-based therapies are not used. Too arousing, not enough cognitive control. They used to use biological treatments when they were first kind of toyed with in the 50s and the 60s. So sometimes they would do surgery, remove part of the frontal lobe for a person with schizophrenia. Early days, they used electroconvulsive shock therapy. That is no longer used on schizophrenia. The first medications, in fact, came out in the 1950s. So these medications for schizophrenia have been around for an awfully long time. And that first category of medications were called the conventional antipsychotics. So let's talk about these conventional antipsychotics here. They are traditionally called phenothiazines. So this is the phenothiazine class of medications, and they include some of the older antipsychotics like Thorazine and Haldol, these medications. And these are helped by about 65% of patients are helped by these. So they do help an awful lot of people. The biggest problem with them is that they've got some side effects, which I'll talk about in a moment. The phenothiazines work by blocking the D2 receptors. So remember, we talked about those dopamine receptors, and they act on the positive symptoms primarily. And I cut this off, but their poor effectiveness on the negative symptoms of schizophrenia. By the way, these phenothiazines, I don't know if you knew this, but they actually have an antihistamine at their nucleus. So in a way, they contain some antihistamines that we all take for allergies. So a lot of these medications cross over. This doesn't mean when you're taking your antihistamine for your allergies, you're taking an antipsychotic. Not at all. But the thing that has moved us away from the phenothiazines in great demand is because of these side effects. So there are two main categories of side effects with the conventional antipsychotics. The first category are called extrapyramidal symptoms. This is a category of side effects, extrapyramidal symptoms. These involve neurological and motor side effects. And the main kind of side effects that are involved are symptoms like Parkinson's disease. So remember I said that Parkinson's disease involves a depletion of dopamine. If we give antipsychotics, that's going to deplete the dopamine. So it involves things like tremors, muscle rigidity, some of the other things here, trembling of the extremities, the shuffling gait, reduced arm swinging. So if you have a grandparent or older relative that has Parkinson's, you'll recognize some of these symptoms. So that's one category. The second category of symptoms, which tend to be even more troubling to people, are a group of symptoms called tardive dyskinesia. You've probably heard of this. These are symptoms, side effects that come around after usually longer term use of the medication, usually after about a year, and they involve tics or twitches, involuntary movements of the tongue and of the mouth. Now, only about 10% of patients develop these, but they can be really severe. It can be like lip smacking, it can be leg shaking, really unfortunate. And you can see some of these in this video that will link in the comments or the description section. So just watch 30 seconds to a minute so you can see. So in those older neuroleptic medications, these can develop and be very uncomfortable and very unsightly for people. And they will go away after you discontinue use of the medication, but it can certainly take a while. So those are all the older antipsychotics. What we generally reach for now are the newer, called atypical antipsychotic medications. Here are some examples of some of the trade names you may have heard of: Risperdal, Zyprexa, Seroquel, Geodon. Now, some of these are also used in the treatment of depression and bipolar disorder if people have some atypical symptoms. So you may have seen those certainly pop up in other places. So these medications block dopamine as well, but not so much the D2 receptors. They block more at the D1 and the D4 receptors, and they also work on serotonin. So these are more broad-based antipsychotic medications. They work on more neurotransmitter receptors, and they are more effective. About 85% of people with symptoms are helped by these. These also help to reduce the positive and the negative symptoms. So that's something that the conventionals don't do. And they also have fewer side effects. The main problematic side effects from these are weight gain, low white blood cell count, so people their immune system might not be great, they may be more susceptible to illness. But really, one of the biggest problems with these is non-compliance, not taking the medication. Because people with schizophrenia, depending on the degree of illness, they may not be able to take medication regularly. They may not have a supportive family who helps them with that. So what's been the solution for this are injections. Many of these medications are now injections, and people can go to their physician and get injections. It depends, either a weekly or on a bi-weekly basis, and then they don't have to remember to take medication. So for people who are really sick, we found this is a good alternative. Okay. So that's it for medication. Now, how about psychological treatment? I just want to mention a couple of things about this. What kind of psychological treatment would be appropriate for a person who's very ill? One of the main things, depending on the degree of illness, is something called ADL training. ADL are called activities in daily living, and these are the things that most of us take for granted. Brushing your teeth, taking a shower, washing your clothes, being able to fix food for yourself. For people with schizophrenia, these are sometimes a real difficulty. So training with this in interpersonal care is, how to handle money, table manners, one of the first things that's involved. And then family intervention is important. As we've talked about, for families who are high emotional expression, we want to try and move them to low emotional expression. And we also want to give some family education about schizophrenia, because education is really the key, the first key to moving people from HEE to low EE, which is what we want. We also can do, and I don't have this on here, but relapse recognition. So we teach families and even the patient themselves how to recognize when their symptoms are starting to flare up, and then to get to the doctor or to notify someone before they kind of get out of control. Now this next slide, you certainly don't have to remember all this. I just want to give you some examples of some of the things that we can use to train families to move toward the low EE side. Oops, let's get this back here. Here we go. Okay, so we teach families to communicate briefly, concisely, and clearly. That's really important. Don't ever make fun of a delusion or try to talk the patient out of it. Don't publicly embarrass the person. Excuse the person if they need time for themselves, and provide a quiet place with minimal distractions. Help the person find leisure activities that are low sensory input, and then develop a quiet, calm, confident attitude, because your attitude is going to make a big impact on the family member that has this disorder. Okay, the final slide here. What is the long-term prognosis for schizophrenia? For most patients, it is not a long process of deterioration. It's not usually a long continuous process of deterioration. Symptoms will oftentimes plateau about 5 to 10 years after the symptoms begin. Now, I'm not saying that's true for everybody. Some people continue to get worse, but other people will certainly get better. And many people with this disorder are able to live on their own or live in community housing where there is just some assistance. So here are some factors associated with a more favorable course for schizophrenia, people who do better or go into remission. First of all, good promorbid adjustment. What this means is how well were they doing before they got sick? If this kind of comes on suddenly, and this is actually the next one, acute precipitating event, if this just kind of comes on suddenly where there was no sign, none of those developmental precursors, generally people will respond better to medication and do better in the long run. Not always, these are generalities. Later age of onset, so a person who develops symptoms in their early to mid-20s is probably going to do, or even later, is probably going to do better than someone who develops symptoms when they're in their teens. The type, so a person who has mostly positive symptoms of schizophrenia as opposed to negative symptoms is going to do better. And then having a supportive family, as we've just talked about, all those things make for a better prognosis for schizophrenia. Okay, so that's a lot of material. I appreciate y'all hanging in with me, but it's just, as I've said, the most complex psychological disorder and one that we just have the most information to share about.